Good afternoon and welcome to the 2021 series UCI Minds Ask the Doc. My name is Josh Grill. I'm the director of the UC Irvine Institute for Memory Impairments and Neurological Disorders, or UCI Mind. About a year ago, a couple of years ago now, we began our Facebook Live series, Ask the Doc, where viewers had the opportunity to log in and ask questions live of Alzheimer's disease and related dementia research experts. We've expanded this series now to include Facebook and YouTube, and today we have a real treat with a special session of Ask the Doc featuring three outstanding investigators here from UC Irvine who are focused on the link between Down syndrome and Alzheimer's disease. So thank you very much for joining us today. I am very confident that you're in for an excellent program. I'm going to begin by introducing our three panelists. And then once I've introduced each of them, we will begin taking live questions. And we also have the opportunity for people to submit questions in advance. And so we will work through as many of those and as many of our live audience questions as we are able to do in the next hour. So again, thank you for joining me, and I'd like to now introduce our panel. Today I'll be joined by three internationally very well-respected experts in the field of Alzheimer's disease and Down syndrome research. First, Mr. Eric Doran holds a master's degree in genetic counseling from right here at UC Irvine, and he's been involved with the Alzheimer's Disease Research Center for now 20 years, working with individuals with Down syndrome and their family as they participate in research here. Eric's research interests include both the development and aging in individuals with Down syndrome and a primary focus on the connection between Down syndrome and Alzheimer's disease. Please welcome Eric. Eric, thank you.
Good morning. Good afternoon, rather.
Next, I'd like to introduce Dr. Ira Lott. Dr. Lott is UCI's Down syndrome program and the Down syndrome core leader for the Alzheimer's Disease Research Center here at UC Irvine. He completed his medical degree at the Ohio State University College of Medicine, followed by training in pediatrics, neurology, and child neurology at the Harvard Medical School. After positions at the National Institute of Child Health and Human Development and at Harvard, Dr. Lott joined UC Irvine in 1983. He subsequently served as division chief for child neurology for 27 years, chair of pediatrics for 10 years, and associate dean of clinical neuroscience for 7 years. Dr. Lott is a widely respected clinician, has been noted as one of the best doctors in America for the last 25 years, and has been a key member of UCI Mind, leading our efforts in Down syndrome research for several decades. Please join me in welcoming Dr. Lott.
Hello, everyone.
Thank you, Dr. Lott. And in just a moment, we will also be joined by Dr. Elizabeth Head. Dr. Head earned her PhD in neuroscience from the University of Toronto and then did postdoctoral training right here at UC Irvine. She recently returned to UCI after a stint on the faculty at the University of Kentucky. She's now the vice chair for research in the Department of Pathology and Laboratory Medicine. She holds numerous additional roles, including serving as the leader of our research education component in the Alzheimer's Disease Research Center and co-leading a new center in the School of Medicine on aging and Down syndrome. She will be joining us momentarily. There we are. Hello, Liz.
Hello.
So again, I just want to thank each of these three very busy, very outstanding individuals for taking the time to do this program where we bring the world's best experts to our community of advocates, supporters, participants, and community members to answer questions. So to kick us off, I'm going to ask one of our pre-submitted questions to Dr. Lott, and it's the perfect one to get us going. Dr. Lott, could you briefly explain the link between Down syndrome and Alzheimer's disease?
So the link between Down syndrome and Alzheimer's disease really was brought to light in around 1948 when a pathologist in the city of New York had occasion to look at postmortem brains of 3 relatively young adults with Down syndrome. And he was surprised to see signs of Alzheimer's disease in the brains of these individuals. So over the next, really now it's around 70 years, there has been tremendous interest in this relationship. What we know just overall is that by the time people with Down syndrome are 40 years of age, there are findings in the brain that are basically identical to Alzheimer's disease in the general population. I don't think there is any other population in the world in which this link has been that strong. Now, that does not mean that they all get dementia. Whether they get dementia or not depends partly on age, from 40 years on, and to a host of other factors that we're investigating. We know for certain that one of the genes on chromosome 21 is essential to the manifestations of Alzheimer's in people with Down syndrome. And that is the gene that makes amyloid, which is one of the chemicals that occur in the brain of people with Down syndrome and in AD in the general population. But there are other factors. So we've been working with UCI Mind now since about 1985. And there are 2 overall questions that stimulate our interest. One is, in what ways is Alzheimer's disease and Down syndrome similar or different than Alzheimer's in the general population? And what determines who gets symptomatic and who does not? So in the course of the next hour, we'll probably dwell a little more on some of those things.
Great. Thank you. Liz, we got a couple questions submitted in advance about the rate of Alzheimer's disease and Down syndrome. Do we have a sense for whether people with Down syndrome who get Alzheimer's disease experience a faster or slower clinical progression of Alzheimer's disease?
Yeah, I think our perception from this, and I'm sure Ira and Eric can speak to this too, Ira's had a lot of direct experience with this, is everything seems to be a little bit more condensed in terms of when things are happening with age and people with Down syndrome. As Dr. Lott mentioned, by the age of 40, we have full-blown AD pathology, and that's already a lot younger than what we see in the general population, which is typically 65 years and older. In terms of clinical decline, it does appear that people with Down syndrome do go a little faster in terms of the rate of the progression of their dementia. But that can be modified by a lot of additional co-occurring illnesses. For example, new onset seizures might be an issue in a person who's developed dementia, and that might move that progression a little bit more rapidly. So part of the research, again, that Dr. Lott and Eric and I are doing is to try to understand what variables are key here for the rate of progression of dementia in people with Down syndrome. Because if we figure those out, maybe these are targetable for interventions.
Yeah. Eric, there's a question about what types of symptoms people with Down syndrome might present with when they first begin to develop Alzheimer's disease, if they are going to develop dementia. Could you kind of overview for folks what they might be on the lookout for or have to expect if that's happening?
Yeah, sure. So in the early stages of dementia in individuals with Down syndrome, families who come into our clinics will often describe the first things they notice might just be a general slowing in their ability to carry out their activities of daily living. So where they were once independent for showering, bathing, dressing, doing their laundry, maybe they still are, but these sorts of tasks are taking them longer. They'll also report subtle changes in behaviors. So the individual will often look as though they have a depression. They exhibit social withdrawal. They tend to isolate more, spend more time in their rooms, aren't as engaged when friends and family come to the home to visit. And these are somewhat different symptoms than you might see in someone from the general population who develops Alzheimer's. We often think of memory changes, right? Forgetfulness, forgetting what we did, forgetting what we just told someone, forgetting the names of friends. But in people with Down syndrome, those symptoms are common in the early stages, but often not the first reported sign. So you'll see changes in memory where they forget what day it was. People with Down syndrome tend to be very oriented to the calendar, oriented to birth dates of friends and family. So families will notice little slips there where they're having trouble staying oriented to day of the week, season, year, things like that. Those are some of the common early stage symptoms that families report to us.
And Ira, if a family believes they're observing some of these changes, is that when they should seek a diagnosis of dementia? And what kind of doctor would they reach out to try to achieve that?
Well, in our research work, we've recommended having a dementia screen at age 40 years so we can establish a baseline. I think physicians in the community are increasingly aware of the symptoms of Alzheimer's disease in people with Down syndrome. This was not always the case. One of the facets that have helped is the establishment of healthcare guidelines for people with Down syndrome. Now, this was well known in the pediatric community for 20, 25 years, but more recently, the healthcare guidelines have been established for adults with Down syndrome. So I think the general physician is getting more acquainted with these symptoms, but there's still a lot of educational work to do. That's one of the missions of UCI Mind, is to bring the adult practitioners along. You know, the fact of the matter is that an internist or a family practitioner have a busy practice and perhaps has one person with Down syndrome in the practice, maybe two, rarely three. So it's not an issue they address every day. So we're trying to help them do that. But I would say 40 years would be the time for kind of a baseline assessment.
Liz, do we know if family history of Alzheimer's disease affects Alzheimer's disease in people with Down syndrome?
That's an excellent question. And I can't really find any literature that speaks to that. So, but I do know there's some researchers that think that if mom has Alzheimer's disease in the family, that there may be an increased risk or an earlier age of onset of Alzheimer's disease in that person with Down syndrome. But that's still an entirely open question.
So I'll take this opportunity to remind folks that they can submit questions via Facebook or YouTube, and we will answer them right here live in this moment. I'm gonna ask a question and give each of our panelists an opportunity to answer it. It actually surmises several questions that we got in advance, which is, what can people with Down syndrome and their family members do to try to lower risk or stave off memory problems and dementia as long as possible? And Ira, I'll start with you.
Okay, so I think one thing that can be done is to keep the person with Down syndrome as healthy as possible. We do know that there are a number of what we call comorbidities, which means co-occurring medical conditions they can actually mimic dementia, but are otherwise directly treatable. They include hearing loss, visual changes, thyroid functioning, sleep disorders, situational depression. The list goes on. And so by attending to the common comorbidities, that would be a big step in keeping people healthy and less susceptible to Alzheimer's. Also, keeping people stimulated. In the early days when this field started out, many people with Down syndrome, unfortunately, were in institutions where they received little stimulation. And I think the burden of Alzheimer's was actually quite a bit higher then. So involvement in a day program, hobbies, and that sort of thing, and attention to the medical comorbidities, I think would be the place to start.
Eric, anything you want to add to that?
Yeah, the two other things that come to mind, and we're just now starting to do research in this area with some of our colleagues across the country, and it relates to something we've learned about Alzheimer's disease in people without Down syndrome that might give some benefit to reducing risk, and that is staying socially engaged, as well as doing or completing moderate exercise on a weekly basis. So exercise has shown some benefit both in people with Down syndrome and people without, as well as staying socially engaged. So trying to make sure you're going out and visiting other people and joining social groups and things like that. Those are important too, as well as diet. This is not an area we have much data in people with Down syndrome, but in general, it sounds like if it's a heart healthy diet, it's probably a brain healthy diet as well. Great. I don't know if Liz has anything she'd like to add.
Yeah, that was pretty
comprehensive.
Is there anything else you want to go on
there? There's another question that we often get that's related to that, and when do I start all of these things? And I guess as Dr. Lott had explained, Alzheimer's can be seen as a condition that starts in early adulthood in people with Down syndrome. So there's no harm in starting as early as possible. And most of these recommendations are good for a whole host of other health conditions that we all are at risk for as we age.
And I would presume that those recommendations are also equally good for once a person has memory problems or meets the criteria for dementia, to try to maintain quality of life and slow the course of the disease as much as possible. Would anybody like to comment on that?
I think there's some very good evidence from actually animal models that all of these lifestyle interventions and changes are not only benefit the young brain, they're also a benefit to the old brain. So the good news is our brains and the brains of people with Down syndrome have lots of opportunities to kind of remodel and repair. So they're all great things to do.
There was one question about the other end of the Alzheimer's disease spectrum, which is the end of a life with dementia in people with Down syndrome. Are there signs that the end is near? That was one of our pre-submitted questions about what end of life looks like for a person with Down syndrome and Alzheimer's disease.
Well, I think the end of life in a neurodegenerative disease and Down syndrome looks very much like it does in the general population. Loss of abilities, loss of communication, loss of vital functioning. The brain has a way of end stage reacting no matter what the condition is. And it is, of course, that stage that we're working very, very hard to try to prevent.
Mm-hmm.
Ira, there's a question about glucose intolerance and the idea of ketogenic diets, and whether they might be beneficial for people with MCI or Alzheimer's disease and Down syndrome. Could you address whether the ketogenic diet has been studied in Alzheimer's disease and Down syndrome, and what, if anything, we know about it?
So problems with glucose metabolism are not uncommon in people with Down syndrome. They have a tendency toward diabetes, generally type 1 diabetes, maybe related to obesity and a variety of other factors. And so we do recommend measures for glucose control. Now, the ketogenic diet is a little more problematic. Its use is, at least in neurology, is for uncontrolled epilepsy. And it's been pretty well studied in children. In adults, for the prevention of Alzheimer's disease, in addition to being a very difficult diet to administer, I don't think we have any evidence that it strikingly changes the course. And the fact of the matter is, carbohydrates are a necessary part of the diet for internal cell hydration. That's why they're called carbohydrates. So if they're completely eliminated and only protein, we're just not comfortable that that's going to be a long-term strategy for people with Down syndrome, except in special circumstances.
Yeah, thank you. Eric, there's a question about redirecting challenging behaviors in people with Down syndrome and dementia. The person submitting the question noted repetitive speaking, but maybe you can speak to other behaviors that frequently occur through the course of dementia in people with Down syndrome, and if you have observed or have heard from families about specific strategies that might be worth trying.
Sure. Yeah, and I'll also offer there's some excellent courses on these topics that our Alzheimer's Association here in Orange County offers. But the repetitive behaviors are not uncommon for people with Down syndrome. Obsessive compulsive tendencies tend to be more common. We tend to see an escalation in those sorts of behaviors if someone is transitioning to a dementia. So behaviors such as wanting to take everything out of their closet, laying it on the bed, hanging it back up neatly in their closet, and then repeating that again and again. Those sorts of repetitive behaviors might be just what this question is about. They can be challenging to overcome because the individual tends to be quite engaged and is difficult to distract, but that's really what the objective is, to try to distract them from that behavior, bring them into another room in the house, try to engage them in an activity that might stimulate them, and try to get them out of that rut. But these are challenges. There are psychiatric referrals that we often make to sometimes try to treat the behaviors that emerge in the course of dementia in people with Down syndrome, and some of those targeted behaviors with medications that can be alleviated, but it certainly is a challenge.
Thank you. Ira, do you want to add something there?
Yeah, just, people with Down syndrome typically develop behaviors that can be overdiagnosed as psychiatric disease. One of the most common is self-talk. Now, in the general population, if you're going around talking to yourself, people think you may have a form of schizophrenia or psychosis. But we have learned over the course that self-talk is kind of an adaptive function that people with Down syndrome use. So we refrain from considering that a psychiatric complication. In fact, classical psychiatric conditions are less common in Down syndrome than perhaps in the typical population. I think Eric's absolutely right about the obsessive compulsive behavior. People with Down syndrome can be very stubborn. They can have symptoms of OCD. And the latter may be a way of trying to control the environment when things are spinning out of hand for them. So I think awareness of these symptoms and treating them separately from dementia can often be rewarding.
Great. Liz, there's a question that was submitted in the chat about whether we can screen in utero for risk factors for Alzheimer's disease.
Wow, that's a great question. Right now, we certainly cannot. We do know that people with Down syndrome, as Ira mentioned, have that extra copy of chromosome 21, and then they have more beta amyloid protein that they're making. Apparently, we can see that prenatally. That is a protein that we have in our blood and can be secreted. So, but that I don't think would necessarily tell us the age of onset for dementia for that person with Down syndrome, or if they fall into that very rare group that we're seeing of about 10 to 15% of people who get out to very old ages and don't seem to develop any cognitive change or very mild. So no, so far, but the whole lifespan for people with Down syndrome is important to consider when we look at aging and Alzheimer's disease. It's kind of a unique situation that the genetics are really driving a lot of things that are going to start to evolve in the 30s and 40s and 50s.
Great. Ira, I'm going to combine two questions that were submitted in advance. We already talked about the ketogenic diet, but one questioner asks whether there are medicines, foods, or supplements, and another questioner asks specifically about antioxidants as potential treatments or preventions for Alzheimer's, memory problems in people with Down syndrome.
So there are medications that are used to treat dementia, and they're the same in Down syndrome as they are in the general population. One of them is called donepezil or Aricept, and the other one is called memantine. And briefly, these compounds seek to restore the chemical imbalance that occurs once a diagnosis of dementia is made. And it's a little bit like whipping a tired horse. The horse will run faster for a while, but then poop out. So we don't think either of these medications is a cure, but there is some evidence that they can be helpful, at least temporarily. Now, in regard to supplements and vitamins, I think we've got to be a little careful. It is known that the phenomenon of oxidative stress is common in people with Down syndrome and to some extent in Alzheimer's in the general population. This is a chemical reaction that probably represents a dysfunction of the energy part of the cell, which is called the mitochondria. But giving antioxidants willy-nilly is probably not a good idea. Along with vitamins, if you give too much of these compounds in an attempt to be helpful, it actually can be harmful. So what is needed in this field is a new generation of antioxidants that will really target better the mitochondrial dysfunction rather than just throwing a bunch of currently sold antioxidants on the market.
I think I might just add a little to that, Josh, if I could. There's really no good clinical evidence or scientific studies that show benefits of antioxidant supplements or other supplements for people with Down syndrome. And so, but I really do think that when you look at some of the other literature in the general population, the strongest argument is for trying to get all those vitamins and minerals in your food, because each of those antioxidants or different vitamins, they recycle each other and lead to additional benefits. So my impression from reading the literature is that's the better approach, is to try to eat a very good diet.
Yeah, I wholeheartedly agree. There are very few, very few randomized clinical trials to suggest dietary supplements can be beneficial for any health outcome, and none in Alzheimer's disease.
Only if you have a full deficiency. If you have a deficiency,
if you are deficient in something, and if you have an allergy that prevents you from getting that component in your diet, then that is something you should definitely talk to your doctor about. Completely agree. But as far as just adding to a normal healthy diet, there's very little evidence. And on the back of that, I'm going to ask everybody to talk about how we know these things and how we need to move forward to find better treatments and test even things like supplements as possible treatments for people with Down syndrome and Alzheimer's disease.
I guess I'll just start by following up from that last topic of antioxidants. Dr. Lott developed what I believe was the first NIH-funded clinical trial to treat dementia in people with Down syndrome back when I first started working with him in about 2005 or 4. Even the study got funded, and it was specifically to look at antioxidants. Doses of vitamin E, vitamin C, and an antioxidant called alpha lipoic acid. And this work was really built upon work that Dr. Head did in an animal model of Alzheimer's. And we did a true double-blind placebo-controlled study where we had half of the group out on a placebo and half out on study medication. And we didn't cause any harm. It was a safe group of antibiotics to administer, but we also didn't see any benefit. It didn't improve their functional abilities, and the rate of decline was the same in the in the treated group versus the untreated group. So that's one of the ways we know this.
Yeah, I would argue it's the only way we know the answers to these important questions. Go ahead, Ira.
So let me try to address this question about therapeutic targets, because it's a tremendously important question, and it really is one of the reasons that we're doing all this research. So let me just take a moment and tell you what we go through when we try to line up people who may be good candidates for a therapeutic trial. So if someone comes into our Down syndrome program regarding Alzheimer's, the first thing we do is a careful medical and neurological examination. And we have 2 neurologists who have gotten very interested in this field who are helping me. One is Dr. Dora Tortillo, who's a pediatric neurologist at CHOC. And the other is Dr. Robert Simon, who is a retired general neurologist who saw lots of patients with Alzheimer's in his general practice. And so we examine the person with Down syndrome, trying to make certain there are no comorbidities that require treatment, and to try to determine what is the actual medical status. Then there are neuropsychologists on the team that do objective testing, standardized testing. You know, in the early days, it says, well, you can't test people with Down syndrome because they have baseline intellectual disability. Well, we and others have shown that's not correct. There are some very sensitive tests. And so we get that baseline medical and psychological profile. And then we all sit together in what is called a consensus conference. And this is still the gold standard for diagnosing Alzheimer's disease. Everybody has input into the process. We decide as a group, is the person cognitively normal? Is the person borderline, what we call mild cognitive impairment? Or is this a frank case of dementia? And then our grants are looking at a whole host of biomarkers, imaging, blood biomarkers, markers of the spinal fluid. Liz can speak specifically to these. And we hope at the end of the day that we not only have a clinical diagnosis, but we have a biomarker diagnosis that will say, this is the person who is at most risk for converting to dementia. And this is where the therapeutic trial needs to take place. And we, in fact, are involved now with 2 clinical trial-ready cohorts as part of our work, and other centers around the country are doing the same thing. So this is kind of the algorithm that we're going through to try to, make the most solid foundation for this work. And, we get referrals and someone has put the patient on Aricept or Emetine or something else because they didn't have this background information. We try to get this information and then make it available to the family and to the primary care physician.
Great. Liz, there's a question from one of our YouTube viewers. It's sort of follow-up to your earlier response, but asking specifically about omega-3 fatty acids.
Yeah, and we're all super excited about omega-3s. I mean, that's a healthy fat, and then we know our brains need healthy fats. So certainly there's a lot of enthusiasm. As before, and as Josh also reiterated, there hasn't really been good clinical trials to show that the omega-3s are truly beneficial. However, they're really high in fish and fatty fish. So there is absolutely no harm, again, in doing this through your diet. For example, the Mediterranean diet, which there is actually clinical data showing the Mediterranean diet is beneficial. That's where you get a lot of these omega-3s from, is in that kind of diet. So, of course, we're not pushing that diet, but of all the papers I've read, and maybe Josh could speak to this too, I think that's the one food that's really enriched in omega-3s that's shown some benefit.
Yeah, there are a large number of epidemiologic studies that suggest, especially not getting enough fish in your diet could be bad for your brain. And there are some ongoing and some previous randomized studies of dietary patterns that have found some benefits of the Mediterranean diet. I'm in particular remembering a study from Spain where people got Mediterranean diet plus extra mixed nuts, Mediterranean diet plus extra olive oil, or a control low-fat diet. And for cardiovascular outcomes, including stroke, they had to stop the study early because the benefits were too good for both of the arms randomized to Mediterranean diet. They were at reduced risk for cardiovascular accidents, including stroke. So a lot of reasons to get that healthy diet, as Dr. Head outlines there. And there's some ongoing studies to see whether diets like that, or the Mediterranean diet specifically, or diet combined with other lifestyle interventions, can reduce the risk or lower the number of people who get Alzheimer's disease.
Yeah. And I like to think of this, especially for people with Down syndrome, because these are, again, they speak to what Ira was talking about with controlling co-occurring pathologies. This healthy lifestyle, reducing all your risk factors, that is probably been the most impactful thing we've learned over the last 10 years about reducing the risk for Alzheimer's disease, is controlling these risk factors. So, and the same would apply for people with Down syndrome in a heartbeat.
Yeah, absolutely. Eric, the same YouTube viewer asks about when a family should think about or consider the group home setting or a more formal care center for their loved one with Down syndrome and dementia. Could you comment about that?
I sure can. It's a difficult situation to try to cope with as the individual with Down syndrome continues to lose some of their abilities. From my experience, the most common point at which a family will start to need to plan for outside of home care or even some significant additional care within the home would be as the individual starts to lose the ability to walk and they become a fall risk. So it can be challenging. Because they will progress to a point where not only are they maybe clumsy and unsteady in their walking or their gait, but they will actually lose the ability to walk. And they can lose the ability to transition to and from the shower, to and from the toilet, to and from the kitchen table. And that takes considerable strength from a family member. And it also puts a parent, especially an elderly parent themselves, at risk for injury. So that's a typical time point when families start to think about outside placement in a group home setting, or as I said, potentially to speak with their regional center service coordinators about getting some more support there in the house. That would be the most common time point. And it's mostly primarily because of that. The physical aspects of care become too great.
Thanks, Eric. Ira, I've got a very timely question. Could you please talk about vaccinations in persons with Down syndrome?
We really don't have any evidence that people with Down syndrome are vaccination risk. There's plenty of evidence to show that people who don't get vaccinated can really get very serious disease. So we have, along with the pediatricians, recommended a normal vaccination schedule. The COVID vaccine, we think, will be very helpful to people with Down syndrome. There's been a flurry of investigations, of course, around the current pandemic. We do know pretty solidly that while people with Down syndrome are not necessarily more susceptible to COVID, but if they get it, the course is more severe. And I think this has to do with an underlying immunological concern in Down syndrome. So we have all lobbied to get people with Down syndrome high on the list of vaccine recipients. And I think it's beginning to happen. So I don't know if there was a more specific question about vaccines, but that's how I would see it.
There was not a more specific question, but just to restate, you are strongly supportive of people with Down syndrome getting their COVID vaccine. Is that a fair way to summarize?
Yes, we think the benefit risk ratio for people with Down syndrome is very high, meaning that the benefits far outweigh the risks, which we have found to be very low.
Great, thank you. We have about 15 minutes left, and I've got a few more questions to work through. Liz, I'm going to ask you, the question pre-submitted by one of our audience members was to speak about the relationship between sleep and beta amyloid, but specifically the questioner asks about over the life course, how that relationship looks and how it might change.
So there's some really elegant work, and we have also Dr. Ruth Benka here at UCI Mind, who specializes in looking at sleep studies in aging and Alzheimer's disease. And sleep is definitely of interest for our group in our big multi-center study to see how sleep might affect cognition in people with Down syndrome when they're older. So over the lifespan, whether or not you get 6 hours of sleep consistently over your entire life or 8 hours of sleep. I don't think there's any data that speak to that specifically. We do know that people who sleep a little bit more tend to be better cognitively. I don't know if that necessarily leads to reduced risk, but there's an interesting relationship between sleep and beta amyloid protein. You need sleep to clear that beta amyloid protein from your brain. It actually, at night, your brain's trying to clear stuff. So the less opportunity you give your brain to do this clearing mechanism, probably the worse it is for your brain, and especially if you're on that trajectory. So we still don't know all the functions of sleep, but certainly there's some good evidence that it's beneficial to get good sleep. I mean healthy sleep when you're older, and certainly when you're younger. It is definitely good for your brain.
Great, thank you. Eric, do we have any screening tests for Alzheimer's disease in people with Down syndrome? Are there routine tests that we could apply at a given age to say we think Alzheimer's has or has not begun?
Yeah, that's a good question. And really up until, I guess, this last year, most of the screening tests that were available were really research-based tests. But the Journal of the American Medical Association just recently updated the healthcare guidelines for adults with Down syndrome. And in that guideline, there is a recommendation that people with Down syndrome receive an annual dementia screening beginning at age 40. And unique to this guideline is a recommendation for a specific screening test, a screening test that's publicly available that any clinician can go to a website and download. Screening test that's available in 12 languages now, I believe, and it's developed by the National Task Group for Best Dementia Practices in Persons with Intellectual Disabilities. And the test is called the Early Detection Screen for Dementia and Down Syndrome, I think it is. But it's publicly available on a website, and it's an informant-based measure where actually the family member can fill it out themselves, and it's an excellent tool because starting at age 40, it's an age when we certainly don't expect anybody with Down syndrome to have dementia, but that's the age when the risk begins. So by starting at age 40, it gives a clear snapshot of where that person is at their adult best. And then that tool can be compared to future administrations of the tool to really detect dementia-related changes. So we're excited about that because it's really the first tool that the average community clinician has at their disposal that's been well studied.
Yeah, I could also maybe add to that one of the research programs that we have that we're most excited about here at UCI is called the Alzheimer's Biomarker Consortium for Down Syndrome, or lovingly known as ABCDS. And the purpose of that whole program is to find other biomarkers, maybe something from blood, maybe something from MRI scans or PET scans, to give us a hint of when somebody with Down syndrome is going down a good path or not so good path. So ultimately, what we're all hoping as a team here is we'll identify maybe a pattern of changes in the blood or in the brain or through cognitive assessments that tell us what trajectory that person will have. And then those very same measures that we learn about in this study could then be used for clinical trials as outcome measures, so we know when we're actually helping somebody with Down syndrome. So that is something I'm hoping over the next 5 to 10 years, we're going to get a much, much better answer on.
Go ahead, Ira.
So I just want to make a couple of comments. One of them is about Josh Grill. Of Josh's many contributions to the field of Alzheimer research, one of the most important has been determining research attitudes of people who would be amenable to clinical trials in Alzheimer's disease. And there is a well-established questionnaire that Josh had a major role in developing, called the Research Attitude Questionnaire. Now, that has not ever been used in Down syndrome. And, based on what Liz is talking about with the biomarkers, we need to understand what the research attitudes are for people with Down syndrome and their families. So Eric has taken on this project through a website which is called Down Syndrome Connect. Many of you may know about this. It's part of the National Institute of Child Health and Human Development. And we have sent that questionnaire to we've had almost 1,000 replies from that mailing. Most of the families are very young. So they have children and adolescents and young adults with Down syndrome. And we are actually dropping the age of our research studies down to age 18 years for a number of scientific reasons. But we need to know more about how people connected with Down syndrome see research, see whether they would be willing to engage in clinical trials. Because the NIH has designated Down syndrome as one of the major factors now for understanding Alzheimer's disease. This was not always the case. This is the result of the scientific advances. It's the result of all the lobbying that has been done on behalf of people with Down syndrome. So people with Down syndrome are now being considered for clinical trial intervention. And I will predict in the next 5 years, there are going to be some very interesting candidates for clinical trial intervention from these clinical trial ready cohorts. So learning more about the attitudes of people in the community about research is going to be very important to us. So I put you on the spot, Josh. Well, I want to comment on your RAQ.
I'll comment to say thank you for your kind words and the wonderful opportunity and honor to collaborate with you on a project, Ira, because for many years I've looked fondly upon your work and the importance of it. And I think it's important that our audience know that we're doing research in Alzheimer's disease and Down syndrome for the same reason we're doing research in Alzheimer's disease in people without Down syndrome, which is to do something about it and to make people's lives better, and ultimately to find ways to treat and prevent people from ever dealing with these diseases. And I do heartily believe that clinical trials will be the ultimate pathway to making those changes in people's lives. And I'm honored to have any role in this. And I'll only add that Scott Kim, Jason Karlowish, and John Rubeck really developed the RAQ, and I'm happy that we've been able to use it as a tool with you and in other studies. So we have about 7 minutes left, and I do have a couple closing remarks, but I'm going to read one last question, and I'm going to give you each a chance with it because I think it's really a nice way to finish the program. One of our audience members, as I'm sure you've known many people who were similar, was not expecting dementia to be an outcome in their loved one with Down syndrome, and they were taken aback by this and struggled. And she asks, how can she be a part of finding solutions and helping prepare other families for this situation? So I'm going to give you each a chance. Eric, I'm going to start with you. How can people help more in our research or in helping other families?
This is a timely question, and thank you, because this is an area that we are trying to make some great strides in. So in our most recently funded grant from the NIH, one of our objectives is to learn more about how we can educate the communities on the issue of Alzheimer's disease and people with Down syndrome. And it's a consortium group of investigators at 8 clinical sites around the country. And at each site, we are going to convene focus groups where we speak with family members of people with Down syndrome, both who are currently experiencing dementia, those who are not, some who are currently participating in research, others who are not, to learn more about what sorts of things they would like to see made available to them. And from my experience in working with this population, the education piece is really critical here. When most of us think of Alzheimer's, we think of a condition that affects the elderly. And we don't expect to see Alzheimer's disease in middle ages, but in Down syndrome, that's in fact what it is. And the education component is, I think, a critical part to what we do here at UCI Mind, why we're having events like this. But we're in a little silo here, and I'd like us to get to the point where nationally and globally, even, we have an opportunity to educate more people. So we will be reaching out to find community members to participate in these focus groups, and you're welcome to reach out to us to be part of it too. So please do.
Great. Liz, what would you like to leave our audience with?
I think self-advocacy is really an important part to this whole issue. Being a participant with the Down Syndrome associations that are local, there's also the National Down Syndrome Society, and the websites do have a lot of information. So some of it's just we need to spread the word. And certainly like an activity like this, but we're hoping with this bigger study, and Eric described some of the objectives, there'll be more online materials and webinars that people can log into and learn more about this. So, but we definitely need to do much, much more than what we're doing now.
And Ira, last thoughts from you. How can people get involved and help us?
I would say just be part of our community. We're going to be sending newsletters out. There's going to be information on the web. Keep yourself posted about this. If you feel you want to have your loved one with Down syndrome participate, we're ready to accommodate your interest at any time. We have people who we have followed, Eric and I have followed for what, 30 years, Eric?
Yeah.
They've gone all through the cycle, and they've been very grateful for the responsiveness of the UCI team. So keep yourself educated about this, about UCI Mind, and together we're going to hopefully find a solution.
Well, we had a good start today. We had 170 people register for this event, which I think is fantastic, and we are obviously committed to growing this community of researchers, participants, family members, and other advocates. So I want to thank each of you for taking the time to join us today. This was no surprise an outstanding source of information for our community. You all did an excellent job, and I want to make sure our audience understand, the brain power that we gathered here today. We've got 3 truly world-renowned experts on this topic, and we're so fortunate to be in a place where we have so many outstanding investigators who not only are providing a service to the community, but are providing a service to the world and doing their cutting-edge research. So thank you to the 3 of you. I hope that our audience enjoyed this program. This is part of a series, and amid the pandemic, we have really ramped up our online outreach activities and provision of educational programming, and we're committed to keeping that going even after the pandemic ends, which we hope will be very, very soon, so that we can get back out into the community and connect with people to do programs like this in person. The next Ask the Doc series will be with UCI neurologist Dr. Ahmad Sajadi. Those are on the second Thursday of each month, and he's going to focus that session on frontotemporal lobar degeneration, or frontotemporal dementias, FTD. So I hope you'll tune in for that. Please do check out the UCI Mind website at mind.uci.edu for links to other programs. We've launched something new called UCI Mindcast, which includes several series of content, including a new caregiving blog, Ask the Doc videos, sessions such as this one, and other content. So please do check that out. If you're interested in participating in research in Down syndrome, please call the number or send an email to the links that were put up previously. If you're interested in participating in Alzheimer's disease research otherwise, outside of Down syndrome, consider enrolling in the Consent to Contact Registry at c2c.uci.edu. Aside from that, as usual, I want to send wishes of gratitude and safety to all of the members of our community. Please stay safe, get your vaccination when it is available to you, and we will hope to see you in person again very, very soon. Thanks again. Bye-bye.
Thank you.
Bye-bye.